Good evening, everyone. Welcome to the masterclass in critical care medicine. As a part of teaching program, we bring about case presentation every alternate week. And today we are going to discuss about acute cerebrovascular accident. And to moderate this session, we have Dr. Jacob Varghese, who is a HOD and senior consultant critical care medicine at Rajagiri Hospital, Kerala. And I am privileged to have him on this platform because he is a wonderful person whom my career started with. My baby footsteps of critical care medicine started with sir, and indeed sitting on the other side, it's a wonderful privilege for me. And we also have Dr. Chaitanya, who is a consultant intensivist and head of the department critical care at KIMS Gachibowli, and who is also an active member of the Society of Neurocritical Care. So it's wonderful to have you, both of you here. So Dr. Saurav and Dr. Mithun would be presenting the case. So over to you, Dr. Mithun and Saurav.
Thank you, sir. Starting the case, I have 58-year male, a known case of diabetic and hypertensive treatment, businessman by occupation from Coimbatore, who is a left-handed person, came with a chief complaints of left-handed upper and lower limb weakness since last 3.5 hours and aphasia for last 3.5 hours. And now coming to history of presenting illness, patient was apparently normal before he went to sleep at 10 p.m. Patient suddenly noticed left-sided upper and lower limb weakness with impaired speech at 1 a.m. associated with aphasia and deviation of left side of face. There was no history of loss of consciousness, no history of seizures, no history of vomiting, no history of headache, no visual disturbances, no fever, no trauma or fall. Past history patient is a known diabetic and type 2 diabetes, known case of systemic hypertension for past 5 years on regular treatment. There is no history of previous similar complaints, trauma or surgeries in the past. Personal history, he is a mixed diet taker, no other social habits, normal bowel and bladder habits, and normal sleeping pattern. And there is nil significant family history. Medication history, patient was on metformin 500 mg BD and glimepiride 1 mg BD and clinidipine 10 mg OD. And he belongs to upper middle class and rents a departmental store. Next.
Dr. Mithun, I think
yes, sir.
You know that intensive care cases always starts with the history, and history taking is very important. And then examination also, and we will have investigation examination at our foottips. So just want to refresh your memories, everything. So just quickly, you have a case right now. History has been taken. Okay, before the examination, just wind up the history, relevant points, and come to a reasonable conclusion. And then we'll go to the examination. Okay.
Okay, sir. So summary is a 58-year male with the who is a diabetic and hypertensive, came with sudden onset left-sided and upper and lower limb weakness with aphasia for last 3.5 hours. And there is no other relevant family or personal or past histories. So the likely diagnosis being acute CVA, cerebrovascular accident.
Okay. Most probably, sir, he has come within the window period. If we evaluate it properly, we can get to a diagnosis and treat him, sir.
Okay. Okay. So you are considering a neurological cause as your first diagnosis, and your clinical assessments fails that. And did you mention about his conscious level? He was talking. History was given by the patient or somebody else?
Sir, patient was aphasic, sir.
I am not able to history. Okay. Okay. So why that history? I asked. Suppose you talk about the conscious level, whether the patient was unconscious with a weakness, probably one more diagnosis will come into the picture, right? If the patient came in some sort of a post-ictal phase, some sort of a seizure happened, then this can happen. So one of the DDs, if aphasia is a different story, if it is some sort of altered behavior, altered sensorium, or incontinence history we ask. That is why when you take the history, everything has to be asked right from the beginning. So there is because that bowel, bladder incontinence, that history was missing in that thing. That is what a point I want to raise at this juncture. Okay. Okay. Yeah, I think very clear cut. All the mentioned relevant points are mentioned. You come to a reasonable conclusion. That's all DDs we will discuss after the examination investigations point. Okay. Yeah.
Okay.
If Dr. Chaitanya is okay, we'll go
Yes.
forward.
Yes. Caesar pertaining leading questions pertaining to Caesar history should be asked.
Okay, sir. Next, coming to general examination in the ER. Starting from general examination, weight 65 kgs, height BMI was 22.5, temperature afebrile. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema, and sugars was 222, and ECG showed normal sinus rhythm, and 18 gauge peripheral line was secured in right hand, and ABG showed nil significant abnormality, and abdomen was soft and non-tender. Then airway, it was patent and patient was protecting. Breathing, patient was on room air with saturation of 97, 20 per minute, and bilateral air sounds were present and no added sounds was seen. And BP was 160 by 95 mmHg, and heart rate 80. There was no murmurs, and peripheral pulses were felt, and there was no carotid bruits. And CNS examination, GCS was E4, V1, M6, bilateral pupils reacting. Left-sided gas paresis was there, and left-sided dense hemiplegia, with upper and lower limb power being 0/5. Left-sided facial palsy with deviation of mouth to the right side. Patient was aphasic, that is V1, and there was no sensory disturbance was noted on left side, and absent deep tendon reflexes on the left side, and Babitsky's sign was positive on the left side, and cerebral functions could not be assessed due to dense hemiplegia on one side, and NIHS scale was 19. So, next.
Okay, so you have examined the patient. I have a couple of questions about the examination, which I'll come to it later. But having examined the patient, the next step all of us does is that you need to come to a differential diagnosis, substantiating whatever diagnosis you made from the history. You have a set of DDs you make from the history, and you are going to substantiate, you're going to solidate it by after the examination. Correct? That's what we're doing after the examination, right? And I rightly examine the patient with all signs. We come to it a bit later. So I would like you to tell each and every differential diagnosis and tell the points supporting it and if any points against it. Okay.
Okay.
Yep.
My first DD will be acute ischemic strokes.
Agreed.
So the points favoring is patient had left-sided weakness, dense weakness with aphasia.
Sir, patient presented with a wake-up stroke. The time of onset is unknown, and he presented with left-sided weakness with aphasia. Most probably the dominant hemisphere is involved. And regarding acute hemorrhagic stroke, sir, his BP was around 160 by 95, and the onset was slow in progress, so it might be a hemorrhagic stroke, but the onset and the history is not suggestive of any hemorrhage or bleed, sir. Todd's paresis, sir.
I will stop. I will pause for a minute right now. Acute ischemic stroke. Agreed. Your point is very valid, but I think the history what you have given me is 1 a.m. 1 a.m. is the time which we mentioned about the onset. So probably 1 a.m. is mentioned there. Wake up stroke by definition means that when you wake up you find weakness, but I think 1 a.m. you have find that's what the history, right? Am I right?
Sir. Yes, sir.
Though he woke up with stroke, but the last seen time is less within the window period. Like 10 o'clock is the last seen time, and 1 o'clock he woke up with stroke. Though he is a wake up stroke, you have a time window which is less than 4.5 hours here.
Okay.
And the other thing, as you said, the dominant brain, we are having left-sided weakness, but he is aphasic completely. You should have mentioned in the history about his handedness.
Yes, mentioned that.
But for us to assume, yeah, right-handedness, yeah.
So I would like to add on a point to it. See, that handedness, you mentioned left-handedness, which is a correct thing because left-handedness patient, definitely the right dominant will be right. But I have to tell that 70% of left-handed
times
persons will
both.
have a dominant thing in the left itself. Just want to make it a point. Okay, it's not
Yes.
that always it follows the
Opposite
rule.
rule.
50-60% almost that percentage will be there.
Both.
Okay, now in ischemic stroke you have two things, right? What are the two types of ischemic stroke you know?
Sir, embolic stroke, thrombotic stroke, or hypotensive?
Okay, the watershed infarct called as hypotensive, right? I got it. So is there any clinical history which tells you about these two differentiation, embolic and thrombotic? Clinical history or something, examination also you have mentioned that. Some other system you examine, it gives a clue that it could be an embolic stroke.
Sir, cardiovascular examination, any AF or any carotid bruit, if it is present, then might be there is a migration or embolic phenomena.
Carotid bruit correlates towards a thrombotic stroke. There is a atherothrombotic stroke.
Sir.
Okay, most common is atherothrombotic stroke. Whereas cardiologic examination, I agree with you. If when he examined the pulse, if there is a irregular pulse, AF is there, or any murmurs present, I think you have mentioned that. I saw that. I think one thing we support the diagnosis of an embolic stroke. Clear? One more thing I would like to ask you, when you take about the history, please ask the drugs. You have mentioned that about diabetic hypertensive drugs. Sometimes, the histories may not be very clear. They will be taking some medications to reduce the heart rate. For the AF, they'll be on oral medications. That will give us a clue that he'll be having an underlying AF. And again, it's important if you take a stroke, because drug history, the drugs, which is clearly that an oral anticoagulation history has to be taken. Okay. So that gives a clue that, okay, it could be an embolic phenomenon. Agreed. Hemorrhagic stroke.
Murmur as well.
Murmur as well, yeah. Murmur as well. Hemorrhagic stroke, what are the two types? I mean, at least a common type.
Sir, either it is a lobar bleed or it is a deep-seated.
Okay. Intracerebral hemorrhage.
Sir.
So what clinical history diagnosis can point towards intracerebral hemorrhage compared to thrombotic stroke?
Patient might have a history of sudden headache.
Rapid onset of maximum weakness is a one history which tells you about it could be a intracerebral bleed calling for an hemorrhagic, you won't call hemorrhagic, acute intracerebral hemorrhage. Okay, fine. Third one, Todd's paralysis. Okay, we might discuss that. Yeah. Your points supporting, your points against.
So points against it, there is no history of any seizures or involuntary activities. And the consciousness level is intact. So it is against the differential diagnosis of Todd's paralysis.
Okay, possible, but no history of seizures, not documented anything. Incontinence is not there, and definitely, his postictal phase is not mentioned. So classical history is missing in that. Correct? Agreed. Okay. Fourth one.
Meningitis encephalitis patient will have a gradual history, sir, gradual progression, and the history of fever.
Okay. Okay.
Any examination, any neck rigidity.
Okay. Will you expect a dense hemiplegia or a hemiparesis with facial deviation when you have a meningitis encephalitis? Unless you want to call it a TB with arteritis vasculitis. That is not there. So no history, no neck rigidity, and the focal neurological deficit doesn't fit completely into a meningitis encephalitis. Okay, points against it.
Unless there is a structural pathology like
structural pathology. Okay,
TB.
yeah. Fourth one is?
So hypertensive encephalopathy, on initial BP assessment, it was 160/95. But hypertensive encephalopathy, there is no other findings like any visual disturbance, any loss of vision, any seizures, any history of any acute pulmonary edema, any other symptoms suggestive of any hypertensive end organ damage.
Okay, you don't need to get all end organ damage together. One end organ damage, like encephalopathy, can happen. But the manifestation of somebody waking up with weakness, slurring of aphasia, with facial deviation doesn't fit into a hypertensive encephalopathy. Okay, but BP is also not very high. It's not suggest a hypertensive encephalopathy. Okay.
Again, when we have a focal deficit here, hypertensive encephalopathy would be systemic, so you might expect something more diffuse rather than a focal deficit.
Focal deficit. Okay. And migraine, atypical migraine.
Sir, migraine, when it is associated with aura, it can cause some kind of focal neurological deficits, but a patient needs to give a history of migraine, any drug, any treatment history for migraine. So a migraine with aura can be ruled out in this case.
Okay. So what is that migraine called as? Something come with the weakness. It's the name for that.
Hemiplegic migraine.
Hemiplegic migraine. Okay. Hemiplegic migraine. And that if something that doesn't suggest that kind of aura or nothing is explaining that, right? Okay. So
Yes.
we will roll out that. Last one is conversion disorder. Yeah.
Patient will have a history, sir. If not presenting, maybe in this first episode in examination, we can rule out conversion disorder because they can't fake the reflexes and Babinski signs. So based
Okay.
upon that, I can rule out
Okay. Last
conversion disorders.
Last in the DDs, you get that. So
Yes.
why did you miss the diagnosis of an intracerebral mass lesion? Does it come like this? Intracerebral neoplasms, something like malignancies in the brain. Does it come like hemiplegia?
Sir, it will be a very gradual onset. So initially, patient will be having headache. Then it will be over periods of weeks and months, and it will be a gradual onset. So instead of an acute attack, it will be a gradual history, sir.
Agreed. Gradual onset is something which points against a neoplasm present like a malignancy. But I'll put one more clue for you. There is if at all there's a neoplasm is there is some sort of a change in the neoplasm can present like acute weakness. What is that change?
Hemorrhage into the SOLs.
Great, good answer. Hemorrhagic transformation or hemorrhage into the tumor, it can present like an acute presentation. So that could be one of the DDs which you missed here. So it should be there. It's not that gradual onset, agreed, but sudden hemorrhage can present like an acute weakness. Okay. Now,
Yes.
I would like to go back to a slide and put that that gaze. Just go back. Yeah. Next one. Yeah. Just look into that. You mentioned left-sided gaze paralysis. So maybe Dr. Chaitanya can correct me because neurology is something which we learned some time back. My impression is that if there is a left-sided weakness, the gaze, it is not paralysis. You talk about gaze preference or deviation. That could be in an infarct or in a hemiplegia because of the infarct. It could be the opposite side. So left-sided infarct hemiplegia means that there will be maybe that what your thought was right, but the deviation will be right gaze preferences or right gaze deviation. That's what I understand neurologically, because weakness, which side weakness in a infarct, in a thrombotic event, the deviation will be opposite side. Whereas in a bleed, the irritable lesions like a bleed, it will be in the same side. So probably the term, it will be right
Term
side.
would be preferential gaze or
preferential gaze.
deviation rather than paralysis. Yeah.
Okay. And quickly before you go to the other things, when somebody asks you about a systemic way of neurological examination, just tell the points what you examine. 1, 2, 3, 4, 5, 6, 7. First one?
Higher mental function, sir.
Agreed. Second one?
Motor stem sensories.
Before motor? Before motor. Cranial nerves comes, right?
You start look at the brain and descend accordingly. So higher functions, cortical features, then you go with cranial nerves, then you come to motor, sensory, reflexes, then comes all these things. Ataxia, bowel bladder, all these things come next. So first you start with higher functions, then cranial nerves, then motor, sensory, then balance, and then go into bowel bladder and all, and then go.
Gate, and last is meningeal signs. Okay, that order has to be, at least you should make it a field that you examined everything. Okay, cranial nerves quickly you can examine the extraocular movements, up and down movements, and then it's very easy. You don't need to elaborate and tell it in our thing, but that order has to be followed. Environmental function is important. You mentioned GCS, but when you write that word HMF, it will be good. Okay.
Yeah, especially when you're trying to localize, when you're saying there is one-sided weakness for any focal neurological deficit, you should also mention which cranial nerves are involved or not, because that will change the localization, whether we are high up or into the brainstem. It depends on that. So whenever you're discussing or representing a patient with focal deficits, we should always mention about each individual cranial nerve also.
Okay, so that is what about the history, and always remember, after the history and examination, precisely put the point and come to a DDs which is narrowed down to 1 or 2 or 3. Okay.
And
Right.
especially in the strokes with hypertension, always also mention about pulse in all 4 limbs. If there is any difference, deficits, even that you need to mention.
Carotid bruit has mentioned. That's what I found.
Carotid bruit is mentioned, but upper limb and lower limb asymmetry in pulses between both the sides. Because there comes dissection and coarctation of aortas. All these also come. Those with hypertension, you need to look for these also.
And just go back to that general ABC. Yeah, because you written the BP, heart rate 80 per minute, no murmur. I mean, because cardiac, but you should mention peripheral pulse as mentioned here. You mentioned about the regularity of the pulse here, because irregular pulse means that you're dealing with a embolic stroke. Okay, so that pulse also in a stroke case you have to mention these things. Okay, yeah.
So here also, when you are doing an examination in emergency, when you write airways patent and protecting, rather than writing that, you can tell out what you examined exactly. For a speaking patient, when their voice is clear, you can mention. Now we have an aphasic patient. So how we are sure that it is patent is again a question. So that also you need to be clear. There is no pooling of secretions and all. For a speaking patient, well and good. But when you have an aphasic patient, you have to be clear on those words, how we are mentioning airway.
Okay, Dr. Midhan and Saurav, I think we have finished the history. Now we have concluded to the diagnosis of possibility of a acute cerebrovascular event. We have put the DDs, we have ruled out certain things, and we have narrowed down on certain things, which could be, most commonly it could be an infarct, which could be an thrombotic event. That's what we think right now, correct? Yeah, move forward.
So MRI stroke protocol was activated, and it showed acute right-sided MCA tertiary infarct with intracranial atherosclerotic disease with aspect score of 7.
Okay. Now, can you tell me why you have chosen MRI?
Sir, our institute has got a protocol in which the MRI suite is just nearby the emergency room, and it can be done quickly, sir. So since a protocol has been made, so in our institute, we prefer for any patient with any monoparesis or hemiparesis, they are shifted for MRI. But as per the guidelines,
suppose at that time, if you had another patient occupying your MRI table, what would you have done?
So then CT non-contrast CT of the head is the ideal investigation to be done.
Okay.
For this case, sir.
Okay. What you would have seen in CT, or because as in your patient you did an MR, what are you going to look for?
Sir, in CT there will be a hypolucency in the area of infarct, and there can be insular hyperenhancement or insular ribbon sign.
See, now we have crossed the history and examination part. Now you know the time window. Though it's a wake-up stroke, you are thinking that he has presented to you in a time window. So accordingly, you tell me what you are expecting in a CT. Your time window is 3.5 hours, right? The patient's presentation is within 3.5 hours. So in CT, what you are expecting, what you look for?
Sir, in CT, we can expect right-sided
CT, first thing you should look is here to rule out your differential diagnosis. Like you had your second differential was a bleed. So first thing in CT is you are ruling out a bleed. Yes. So next, if it is not a bleed, then what do you look for?
Sir, we'll see for the Sulci and Gyri differentiation will be lost on the same side.
So you're searching for
Then,
signs of hyperacute stroke
sir,
on CT. So what all there? There are 3 or 4 or 5 important things which everyone should know.
so then there is usually insular ribbon sign, which is the distant most part of the MCA. And then if MCA is involved, then usually we get a MCA dot sign or a dense MCA sign. And the lenticular part of the area also, there is some hypoenhancement. So usually in CT we get this sign, sir. If
You use
MCA
the
is involved.
differentiation between basal ganglia. Usually you have caudate and lentiform nucleus, which are separated by the internal capsule,
Yes.
which is almost hypodense. When these areas are affected, they all become hypodense. You lose differentiation between basal ganglia. Okay. So you mentioned aspects as 7. Can you tell me what is the score and on which image that is done?
It's done on CT imaging.
Sir, it is done at 2 levels. One is at basal ganglia level, one is at corona radiata level. In this patient, at the basal ganglia level, the M2 segment and the lentiform and the caudate nucleus, there was a hypodensity. So
aspects is usually done on a CT.
Sir.
For a total score of 10, you subtract 1 for each area involved. Okay. So lesser the number, what does that indicate?
Greater than 40.
Greater than 4. So when do you consider it's a very bad stroke? Or based on that, what are you assuming? Why should we look at an aspect score?
Sir, aspect score tells us whether we should go ahead with thrombolysis or thrombectomy, sir, if the score is more than 7, that means most of the brain is intact. They have the circulation is intact. They have still not gone into infarct. So score more than 7, we can go ahead with thrombolysis. And if there is a penumbra which is large enough, we can go for thrombectomy.
Aspects is done on a plain CT, first thing. You're only making a rough estimate of how much area is involved. It will not give you any guidance whether you should lyse or not, whether you should reperfuse or not. It will only warn you that area is big, we might face a hemorrhage. It only guides you, but there is no guidelines or there is no indication for you that you should lyse or not based on aspects. Okay. So, and as you said, penumbra requires some advanced modalities to do. This is only a plain CT. These scores are done so that you will not waste time in identifying what and take a guidance. These are just to tell you when in a plain CT, 1 is there is no bleed, 2 there is signs of hyperacute stroke, 3 if you are thinking of paralyzing, thrombolizing or doing any reperfusion strategy, how risk is it to have, I mean, is there a chance that there can be a hemorrhagic transformation? That's the only thing it's going to guide. Okay, so here you have done an MRI, but you have noted aspects score, so that you should be cautious. It is only on a CT. Okay, so if it is MRI, what does your hospital protocol, what all sequences are done? You should know what sequence to look at. Can you tell
So
2 or 3 sequences which you definitely look at when you have an acute stroke patient?
So here we do DWI, diffuse weighted imaging, followed by ADC and FLAIR imaging.
Okay.
So, if it is in hyperacute stroke less than 4.5 hours, so usually it will show in the DWI as a hyperintense area, but the corresponding FLAIR it may not have been established. There's differences between cytogenic versus vasogenic edema. So if there is a DWI and FLAIR mismatch, that means there is a significant penumbra which can be recovered. But if the DWI and FLAIR they match with each other, that means most probably it has gone into vasogenic edema, and the area may not be salvageable.
We need not talk about edema when we are talking in acute hours, no? It is only about the infarction, ischemic area. There is called core and penumbra. A DWI is the earliest imaging modality where we can catch an infarcted area. If the same area is there in FLAIR, then it indicates that onset has been for a while. But still, not necessary that it will show up on CT, and doesn't mean that it is we can't recover that. Diffusion is the first imaging modality which can capture an early infarct. Okay. What other images? Because your hospital is using MRI as the first tool. What other sequences you need to look at? Based on your differentials, how will you rule out a bleed?
So usually there is a GRE sequence, graded recall echo, which is usually positive for bleed, and it shows a
How will it appear?
hypointense.
Good. Go ahead.
So GRE sequence will rule out any bleed.
Yeah, GRE sequence
And,
susceptibility wide imaging, which will show bleed as a black color on your image, which will tell you there is a bleed. Okay. And the other advantage of doing a CT or an MRI is one other sequence. What is that? Instead of doing a plain CT, when you have the opportunity as your hospital chooses to do MRI, what is that other sequence which is helping you?
these two, DWA FLAIR.
You will be able to image the vessels also in the same sitting by doing a time of flight sequence. You will also know large vessels. You will be knowing how the MCA is or ICA is to decide on your further care. Okay, that's one advantage of doing a plain CT. Okay. Shall we proceed, sir?
Dr. Chaitanya has covered everything. I have only 3 questions to ask you. One, before getting into that MRI protocol, everything, one important thing you should look for is that please do have what is called as stroke mimics. So can you just tell me what are the stroke mimics you look for before you confirm a diagnosis? I mean, before you clinically think that it's a stroke. One, I mentioned seizures, which I mentioned in the history. What all stroke mimics are there?
Hypoglycemia.
Okay.
Sir, hypertensive encephalopathy like press.
That you mentioned that hypoglycemia is a common thing. You should definitely look for the basic set of labs. Seizures you have mentioned. Hypertensive BP, anyway, it is there. Anything else? Stroke mimics you can think of?
Sir, hyperkalemic and hypokalemic periodic paralysis. Yeah, metabolic.
Okay. Some sort of a periodic paralysis. Okay, just want to mention that stroke mimics should be taken into consideration. And even though everything is covered, I just want to ask you, see, MRI, CT, both are available. You know, some centers you don't need to, this is a protocol is different. But tell me, which are the clinical situation or condition states where MRI is taken instead of CT?
Sir, if the time of onset is not known.
Okay, time of onset is not known. Agreed. That is the one thing. Okay. Second thing. Wake up stroke also, time of onset is not known. Second thing. Third thing is that delayed presentation of the patient. Third thing. Fourth thing is that PCA stroke. If you're suspecting a posterior circulation stroke or PCA territory, CT may not give us a clue. That is the one thing MRI holds the key. Okay. Have you heard the term called as MRI guided thrombolysis? Is that term is there or not?
And the time of...
We have discussed that. Dr. Chaitanya has discussed in detail. I just want to put that term in place. There's an article in NEGM 2018, which they mentioned about what is called as an MRI guided thrombolysis.
Based upon the diffuse weighted imaging and FLAIR mismatch, we can go ahead with thrombolysis.
So I don't know whether I'm right or wrong, because Chaitanya can correct. What our neurologists used to tell us is that, or the discussion is that, you know, diffusion FLAIR mismatch, FLAIR takes time to come. How much time? How do you remember is that FLAIR, FLAIR, five are there. So plus one more, 6 hours. So the FLAIR, it is not there. That means that still 6 hours time is window is there. So that is the time which we calculate. So diffusion, FLAIR, mismatch definitely is something which you can consider in wake-up stroke, especially in wake-up stroke, a decision for an MRI guided thrombolysis, which is a guide for us to use that. Okay, thrombolytic gauge. Fine. I think images, everything is covered very well. Nothing more to ask from my side. Dr. Chaitanya, I think we can move forward to the next one. Next slide.
Yes, sir. Yes.
Next, coming to investigations, first blood glucose was 222, and renal function test was done, and electrolyte sodium, potassium, and chloride was performed, which was normal, and the creatinine was 1.2 and urea 26. And in complete blood clone, HB was 15, total counts 10,000, and platelet 250,000, and INR of 1.1, and thyroid stimulating hormone 2.5, and ECG was a normal sinus rhythm, and 2D echo and chest X-ray was done, which was normal. Diagnosis is acute ischemic stroke, right MCA tertiary infarct with left hemiplegia and aphasia, with aspect score of 7 and NIHS of 19.
Okay.
Patient was
have you scored any patient for NIHSS? See, most of the time it happens in emergency, and after that patient comes to ICU. So, but do we still have a role for ICU? Even
yes, sir. We have a role, sir. If patient is undergoing intracerebral hemorrhage, if NIHS score is more than 4 after thrombolysis, then it's a
change in NIHSS.
Yeah. Yes, changing.
Okay. So because you are presenting it retrospectively, now you have come up to thrombolysis, but what are the minimal investigations which are required, or is any investigation required at all to thrombolysis?
Sir, only blood glucose is enough to go ahead with thrombolysis.
Okay. Any other test is required in any special situation you are aware of?
Patient is on anticoagulants, then I need to check for INR levels, sir. If it's more than 1.7, it's contraindicated.
Okay. Okay, you can go ahead.
Again, that in that context, it is important to take the history of anticoagulants, which INR holds good for the older ones, the acetylene and the warfarins, the coumarin derivative. But now we have, you must be aware of that, we have a lot of things called as the DOAC or NOAC, no and all anticoagulations. So that history is important. The time of taking that drug is important. That will come to it a bit later. That if somebody is on a newer oral anticoagulations, whether 10A inhibitor, apixaban, rivaroxaban, or the dabigatran, the diethrombin inhibitors, what time they have taken the last dose. That history has to be very clear if they are on medications. Okay, please note on that point. Yeah.
And same way for in-hospital strokes, if you are, because yours is it's a large tertiary hospital, you also face in-hospital strokes. At that time, you should also note about the DVT prophylaxis doses, prophylactic dose or therapeutic dose, and the last dose time. They are also essential. Okay, proceed. You can go ahead.
Patient was thrombolyzed at 2 a.m. with the alteplase of 10 mg bolus, followed by 80 mg infusion over 60 minutes. And the post-thrombolysis, patient was shifted to ICU for further management.
Before that, Dr. Then just go back to slide. If I ask a question, the patient is a tech savvy, he's Googled a lot and he's asking a question. Doctor, why do you use alteplase? I heard this new molecule is called as something else, is there called as Tenecteplase. So is there a difference between these two, or what is your opinion about that? Alteplase is classically described. I agree with that, right? I think you are clear. We can 10% bolus and rest all give infusion over 60 minutes. But this is a question asked to you. One knowledgeable ChatGPT or whatever social media, whatever. So what is the difference between these two? Alteplase, Tenecteplase.
Sir, Tenecteplase is not FDA approved, sir. Next, on recent NOR test 2 trial, Tenecteplase showed increased intracerebral hemorrhage. Sir.
I beg to differ with that a bit, because that is one interesting topic to think. So TPA, modified TPA is Tenecteplase, right? And the advantage is that it's a single intravenous dose. Correct now? 0.25 milligram per kg, maximum we give 25 milligram. And if you look at the current data, what we can gather is that nobody is saying it is superior, but all are non-inferiority trials.
Non-inferiority trials.
So non-inferiority means that now everyone goes in non-inferiority. So Tenecteplase is found to be, Chaitanya, agree with me, no? Non-inferior.
Yes.
They're all non-inferior trials. Okay. And the risk of intracranial hemorrhage is probably slightly lower with Tenecteplase, and ease of administration is also there. Can give bolus dosage. So
here you can tell what you can answer is here. The AHA stroke guidelines say for first 3 hours it's non-inferior. 3 to 4.5 hours they don't have data. So you have chosen alteplase. We continue to use. We use for ease of administration, cost, all these things. But then right now the AHA guidelines support for first 3 hours as equivalent, almost non-inferior to alteplase.
Okay, please go ahead. Yeah.
On day 1 of ICU, the patient's sensorium was status quo, and dense hemiplegia was still persistent on left side with the power being 0/5. And the patient was protecting airway, and the patient was still aphasic, and the left-sided facial palsy was present. And the injection lateral infusion was used for hypertension. And the next day morning, 6 a.m., patient became suddenly unresponsive with a drop in GCS to E2, B1, M4, and patient was intubated and shifted for CT brain. In CT brain, it was noted to have hemorrhagic transformation of the infarct with a midline shift, and anti-edema measures were started and anti-epileptics, and the emergency decompressive craniectomy was done in view of hemorrhage.
Just go back. I want to ask one question about that hypertension control. So could you just tell me, you have used labetalol. Agree with that drug? That's one thing is commonly available, and we always use that. So what is the target BP you should mention post thrombolysis?
Post thrombolysis, I will target a BP of 180/105.
Less than that, right?
Yeah, less than 1.
Okay. Fine. And
how much of labetalol have used, because you said you're using infusion?
Sorry, sir.
Labetalol dosage, how do you use labetalol?
So usually the dose is around 0.5 to 2 mg per minute. We take a 20 ml syringe with labetalol. 1 ml is 5 mg. So we start at around 5 to 6 ml per hour and titrate the BP accordingly.
Okay. The guidelines say first to use labetalol as a bolus doses to bring down the blood pressure. And when doses of multiple doses are being required, then to use a drug which lowers the BP smooth. If you see, even the guidelines say more BP variability also can precipitate hemorrhage. So we have to reduce multiple usages of boluses. We have to use a drug which is titratable, which has a smoother action. Both in ICH guidelines and the stroke guidelines, the guidelines mention these words, though in a very simple word, but many of times we miss that. Okay. So now you presented that 1 o'clock is your thrombolysis time, and 6 o'clock you have a drop in GCS and you have a CT now. Okay. So how did you proceed further?
CT scan
Your
was
patient
done,
shifted the patient to OT, right?
Yes, sir. CT scan was done, sir. It showed hemorrhage, then shifted to OT, sir.
Before shifting to OT, did you do something else?
Sir, before shifting to OT, initially we collected the samples of fibrinogen, platelets, hemoglobin, cross-matching. Then 1 dose of tranexamic acid was given, 1 gram. And then the patient was given a bolus dose of anti-edema, mannitol and 3% NaCl, and patient was immediately shifted to OT. Was intubated and shifted to OT.
Yeah. So now, should you wait for your fibrinogen report to come?
No, sir.
What should you do?
Correction of
In this situation, where you have given IV alteplase and now you have an hemorrhagic transformation. What you should have done?
10 cryoprecipitates should be
Yeah.
given.
Yeah. You need not wait. You need to give 10 cryo. And later you can check for fibrinogen. And if it is still less than 150, then you could have transfused more. And Trenexa, as you mentioned, is a good one.
And once the bleeding has happened, is there a change in your blood pressure targets? If that 180, 105 immediately post thrombolysis, you mentioned that. But once the CT showing an hemorrhage, I think the initial point is very valid. You don't wait for that. Cryoprecipitate has to be given. Tranexamic acid given. But is there a change in your BP targets?
It will target around 140 to 1.
Yeah.
Systolic
Once the bleeding happens, systolic BP targets will come down again. Okay, less than 140 should be the target. There is no mean. MAP is not mentioned. Systolic BP should be less than 140. And you start the measures, as you mentioned, that manage intracranial pressures. So maybe we'll come to it a bit. What are the measures you do it? You mentioned about anti-edema measures. We'll redefine it to what is called as manage increase ICP lowering measures. So what are the measures? Just it goes systematically.
The tired approach, sir, for management of ICP. First, the patient has to be intubated with head elevated to around 45 degrees. We have to maintain euglycemia, euthermia, normocapnia with adequate sedation. And blood sugar target should be around 140 to 180. And systolic BP targets at around, as per the pathology of the brain. Then tier 1 management, sir, we can start on anti-edema measures, and we can give the appropriate dose of sedation so that the patient is not restless. And in tier 2, we can resort to use of muscle relaxants, and we can do a MAP challenge test in tier 2 if we have an ICP monitor. And in tier 3, we can resort to barbiturate coma, or we can proceed for decompressive craniectomy for management of ICPs.
Barbiturate coma comes next after decompression.
Sir, and hypothermia, sir.
That's the last resort.
Hypothermia is there. You covered your ventilation is there. You mentioned, I think tier 1, tier 2 is important aspects. You mentioned the steps. I think the head and elevation of the bed, all nursing measures, medical and pharmacological needs to be combined with all the tiers. Do you believe in measuring intracranial pressures for this patient, ICP monitoring?
Yes, sir. We measure it.
I'm talking about this patient, talking about this particular patient. Do you believe or do you want to do an ICP, invasive ICP monitoring? Or how do you measure ICP monitoring? What are the methods you do? Invasive, non-invasive?
So non-invasive, we can do bedside echo. We can use, sir, to see ONSD and transcranial Doppler, sir, to see the underlying pressure, sir. But in this
transcranial Doppler will give you the ICP or something else?
And sir, in the initial view, between the outer plate and the inner plate of the brain, we can measure the distance to see.
Indirectly, you can get the pressures inside. Okay. And ONSD, optic nerve sheath diameter, something which definitely a bedside tool can see whether ICP is rising. Do you want to do an invasive pressure monitoring, ICP monitoring for this patient?
No, sir. Patient has just been thrombolized. He is bleeding. So invasive, we'll try to avoid any invasive procedures.
One thing is that. Second thing, even if it is a large, so what is that? Even if it is a large malignant infarction or a post bleed, I think invasive ICP monitoring role is not at all much recommended, right? Recommended. Okay, you don't need to do that. You go by the clinical assessment and go by these measures to look for and see what is happening. Okay, fine. So anti-epileptic, yes, you give prophylactically, or what is the role in this patient? And what drug you prefer to use? Any preference for any drug and dose?
Usually we prefer levetiracetam, 500 mg 12th hourly. There is immediate, there is no role, but for initial 7 days we can prefer giving anti-epileptics, and after 7 days we can withhold or stop it.
Okay, so what other anti-edema medical measures you give to reduce this thing? Anti-edema measures, you know. The
Sir,
drugs.
mannitol 3% NaCl, sir.
Okay, so mannitol, what is the dose? What is the infusion, or what is the target? Dose, and what is the dose? The bolus dose is there, or it's a single dose, or how do you give mannitol, and what is the target?
Mannitol, usually we give bolus dosing, sir. Usually 100 ml 8th hourly, and our target is the osmolar gap, sir, or the serum osmolarity. The osmolar gap should be less than 20. And for 3% NaCl, we usually give it as infusion, 30 to 50 ml per hour infusion, and our target sodium will be 150 to 155 milliequivalents per liter.
3% you will give bolus?
3% NaCl, sir, in case of there is sudden increase in ICP, we can give up to 3 to 5 ml per kg bolus we can give, sir.
It is preferred you always start infusion following a bolus, because to achieve your hyperosmolar state, the bolus will help in achieving it rapidly.
Okay, you come into mannitol. You know, we mentioned about osmolar gap and osmolality. What osmolality number you target? Is there a number?
320.
320. And the dose you mentioned about 100 ml. It's based on the gram per kg, right? We give bolus and then give intermittent intermittent doses. Any idea about the gram per kg? 1 to 1.5 gram per kg boluses.
Sir, yes, sir. Initial bolus is about 1.5 gram per kg.
When should you give a bolus?
Sorry, sir.
Mannitol. When do you give a bolus?
When there's sudden increase in ICPs.
Yeah, when there is sudden herniation, signs of herniation, sudden pupillary asymmetry, signs of bradycardia, Cushing's reflex, all these things, that's when you choose to give a bolus. Bolus dose is 1 gram per kg, as sir said. So how much you give? 1 gram per kg for a 60 kg weight.
How much is 100 ml?
20.
20%,
100
right?
ml,
20%.
100 ml is 20 grams.
20 grams.
Okay.
So 300 ml.
So 300
300 ml mannitol you need to give.
Agreed. Good. What next?
On day 2, CT brain post.
Before that, what are the evidences to support the decompression craniotomy?
Sir, decimal trial, Destiny 2 trial, and Hamlet trials.
Okay, so this gentleman fits into a benefit group, or not a non-benefit group, and based on what trial?
So Destiny 1 trial was less than 60 years, and it suggested that it was to be done within 48 hours.
Okay.
So this individual is 58 years old. So most probably decompression will give mortality and morbidity benefit as per Destiny 1 trials.
Okay. What is Destiny 2? What did it show?
So Destiny 2 is more than 60 years old.
Okay.
But it has not shown any morbidity or mortality benefits, the Destiny 2 trial, as far as decompressive craniectomy is concerned.
Okay. So definitely he fits into that criteria. Is there a difference between dominant and non-dominant hemisphere with regards to outcome in decompression craniotomy? That is dominant and non. You got the question right?
Yes,
Suppose
sir.
the infarct or the changes is in the dominant and non-dominant. I think one of the trials have given that.
We are not aware.
Okay. The non-dominant, the non-dominant hemisphere, if it is, the indication and the results may not be good as a dominant hemisphere. That is what some of the trials, I forgot which was the name of that. But I think based on the Destiny 1, age less than 60 years, definitely there could be benefit. And the most important thing is that do it within 48 hours. Okay, fine. Yeah. So what happened next after the decompression craniotomy?
CT brain was repeated, sir. It showed right frontotemporoparital decompressive craniotomy changes, and the GCS improved gradually from M4 to M5 response. And in view of prolonged ventilatory requirement with the poor cough reflex, percutaneous tracheostomy was done. On day 10, patient GCS was E3, BT, M5 response with the left hemiplegia, and the patient was shifted out for rehabilitation.
So in this patient, because this is a patient of ischemic stroke, should you start aspirin now? When will you start?
Aspirin,
Antiplatelet.
ideally, it has to be started after 24 hours. Thrombolysis.
Yeah, this was thrombolysis. Now we have a complication of thrombolysis. Now here in this particular patient, when will you take a call?
Sir, since the patient has underwent a decompressive craniotomy, sir, once in the follow-up imaging of the decompressive craniotomy, there is no further bleed or the bleed has stabilized or hemostasis has been achieved. Then taking the neurosurgeon's opinion and considering we can start on antiplatelet ecosprin, sir. Preferably single antiplatelet.
The same holds good for DVT prophylaxis also. When at the best, by what time you should have started?
Usually 72 hours after the procedure, or
the hemorrhagic stroke guidelines say by day 5 you should be in a position to start. Even earlier, if you have established that there is no progression of hemorrhage. So maximum is 5th day. Beyond that, you can start. Before 5th day, if you want to start, you should establish that there is no progression in hemorrhage. Okay.
Okay. Now I think we would like to take you a little bit before that bleed happened. You have thrombolized the patient, right? Now let me ask you a question regarding, suppose, somebody asks you what is the role of mechanical thrombectomy. So what do you say about this? When do you decide upon doing a thrombectomy?
the first indication if the patient is not fitting into the criteria for thrombolysis, there is an contraindication for thrombolysis.
Your institute doesn't
we
do
can
thrombolysis and then thrombectomy? Your institute doesn't do thrombolysis and then thrombectomy, or they do only one of these things? Just want to find out.
Yes, sir.
So which is what is the
sir,
criteria?
If in MRI, sir, if in the MRI there is a large vessel occlusion, and usually what we follow here, if the aspect score is more than 6 or maybe 7, and there is a salvageable penumbra, then we proceed for endovascular thrombectomy, sir.
Okay.
So somebody coming within time window, if you establish that it is a candidate for thrombolysis, you should also establish whether he has large vessel occlusion or not.
Exactly.
And if it is there, you need not look for core penumbra and all. You can proceed. Core penumbra comes only when you are out of your time window.
That is the point. So large vessel occlusion, by imaging whatever you're doing, MRI or CT perfusion or CT angio, because that both are, that clearly says that in a hypertensive MCA sign is a large vessel occlusion. Somebody comes in the beginning with a stroke without a hypertensive MCA sign, what you have mentioned as one of the early signs, definitely is a large vessel occlusion, and he is a candidate, might require thrombectomy. Some institute do favor that you give half thrombolysis and then take the patient for thrombectomy immediately for benefit of these things. Okay, that is something. And when you're talking about thrombectomy, Dr. Chaitanya mentioned about within the time. So is there any trend or data or anything which supports larger duration of indication for thrombectomy. You don't need 6 hours. You can thrombectomy up to 24 hours. So what is that term called as? You look into some aspects and then they take a decision of for thrombectomy up to 24 hours.
Extended window.
Extended? Yeah, what? Based on what? Based on what? He mentioned about penumbra, this thing, I mean, all that core group. So that large infarct core, that is something which is the current trend right now. When you talk about this thrombectomy in stroke patient, apart from the classical time window, they can extend up to 24 hours if you do a CT perfusion or MRI perfusion, whatever you want, and you find out about the large infarct core. There are a lot of data. I think somebody has mentioned in the chat box about the trials. There are a lot of n number of trials is happening right now. What is called as there's a term called as the large core trials. It's called as the large core trials. Okay, the large core trials or large infarct core trials. So large infarct core trials gives us an idea about the infarct core, and you can take a decision for thrombectomy within the 24 hours. That window has been extended. Thrombectomy, not thrombolysis. Okay, thrombectomy. Okay, fine. And when you talk about moving forward, have you heard an entity called as thrombolysis-induced angioedema? You've seen that?
Heard, sir, not seen any patients.
Sorry?
We have heard about the term, sir, not seen any patient.
So anything you know about thrombolytic-induced angioedema?
Icabitant is a drug which is.
What is it? What is it?
Sir, I'm not exactly sure, sir. Icabitant.
Yes, even inhibitor.
Icatibant.
Yeah, correct. Because this is a bradykinin mediated. It is not like routine things where a steroids is going to work. So what? That's what something is mentioned there. Correct. I can defend. Correct. So what sometimes you can do is that stop the TPA, and then sometimes fresh fluorescent plasma infusions can immediately help us in reversing the angioedema if nothing is working out. So thrombolytic-induced angioedema is something which can definitely scare you because the edema in intubation is going to be difficult. So that entity is there. Okay, please think about it. And now comes to the next question. We mentioned in the earlier about what is called as a NOAC, the neuro oral anticoagulation, right? So that if somebody is on NOAC comes with a stroke, what is important? I think we mentioned that in the beginning that the timing is important. So any idea about why the timing is important?
The time which he has
It's about
taken the
acute.
last.
I'm not bleeding. I'm talking about an acute ischemic stroke. Somebody is on AF, atrial fibrillation, classical example, and he is on a neuro anticoagulation. So why I'm saying is that history is very important for everyone who's listening. Somebody comes with an ischemic stroke, maybe an embolic and anything. When you take the drug history, please take the drug history of a NOAC, and timing of the drug last dose is important. Because if it is taken less than 4 hours, no intravenous thrombolysis. If it is taken more than 48 hours and the creatinine clearance is more than 50, then you can straight away go with the thrombolysis. But between 4 and 48 is the catch right now, 4 hours and 48 hours. Because if it is a large vessel occlusion between 4 and 48 hours, probably you can consider direct thrombectomy. Don't consider thrombolysis because risk of bleeding is high. So if it is 4 and 48 hours patient coming and LVO is definite there, hypertension MCA sign, your MRI is showing a large vessel occlusion, straight away take the patient for thrombectomy because thrombolysis risk of bleeding is going to be high. And if it is no large vessel occlusion, then the measurement of this NOAC levels based on the factor 10A or whatever, it is not available over here. Probably if it is not a large vessel within 4 to 48 hours, the risk has to be very much high, explained, and then take a decision. So less than 4 hours, clear cut, no thrombolysis. More than 48 hours, normal creatinine clearance, thrombolysis. 4 to 48 hours, dicey situation, large vessel occlusion, thrombectomy. No large vessel occlusion, explain the risk. And somebody has mentioned in the chat box, Reversal agent, you must be aware of the two reversal agent, atezolizumab alpha and etrasimumab should be available. If it is available, keep it ready when you thrombolyze a patient. Okay. Yes. So anything else we have missed? Dr. Ravi, you can pitch in. Dr. Chaitanya, anything else we have missed with them, or we have done with everything? Chat box, anything is there, Dr. Ravi?
Chat box, I think we have covered most of the things, sir. Two questions which you have not
just
discussed.
seeing.
Whole of newer IV antiplatelets like tyrofiban, which is again commonly used nowadays. Actually.
Yeah. I think there's a new data. There's a new data which has come up right now. Where terafeban is being used post,
Lysis.
yeah. So Chaitanya, you can tell more about it because I've not used
Yes,
much.
I mean, still not into guidelines. The current guidelines don't support the use of using infusions of tirofiban or eptifibatide or abciximab. But there is developing evidence from the previous trials and the newer trials where tirofiban was used as an infusion post thrombectomy also, sir. I think post thrombectomy.
It's post thrombolysis.
Yeah.
Post thrombolysis within 24 hours, again tyrofiban can be used, or sometimes when it is out of the window period, people have tried using tyrofiban as when the patient is out of the window period.
Yeah.
Then another question, I think one of the pupillometry somebody has talked about. Our experience with pupillometry is not there. I don't know if any center is really doing pupillometry as such.
Yeah, it's one of the indicator one, but nobody is using it in routine basis for pupillometry. Yeah, agreed.
Again, it is only as a monitoring tool for your raised ICP. Your reaction time to raised ICP might be little faster than doing a manual thing. You have an index, reactivity index, which you can see before even pupils dilate or pupil response is reduced.
Pupil dilatation is something which is always something which is a one-time thing. So pupillometry you can always record and see what is happening. So definitely ONSD, if you have access to it, and you don't need much of a learning curve to do that.
Yeah.
Another question is regarding the sovetletide, actually, the Tyvalzi. I think people are now fancy in using newer and newer drugs, actually. So another question is regarding sovetletide. So I mean,
Sovetletide in non-thrombolysis cases they are using non-reperfusion where they're out of window, where there is no scope for thrombolysis or thrombectomy. I think there is evidence coming up for that as well. It's the only other drug which is showing some evidence, a positive benefit other than thrombolytic agents.
Yeah, I think a single drug marketed in the name of Tyvalzi, actually.
Tyvalzi.
So I think FDA approved in 2023. So given in a dose of 1357, if I'm not wrong, actually. So again, clinical outcomes are slightly better with Tyvalzi, actually, but we have used for a couple of cases. Personally, most of the cases had very mild stroke. Actually, we haven't used for a patient who had a very large stroke. So my experience is also very limited with sovetletide.
So role of transcranial Doppler in stroke, someone just asked. It can help in seeing for, again, a large vessel occlusion. Second, it can, by looking at pulsatility index and all, you can make an assessment of rising ICP. There are other indications in stroke rather than our acute ICU situation where we can look at embolic phenomena, PFOs, AF detection through TCD. All these will help in a stroke patient.
Midline shift.
Midline
midline shift.
Yeah.
So I think we have discussed about anaphylaxis after starting alteplase. I haven't seen any such patient after starting alteplase. Maybe sir was mentioning a lot about that, actually. So we have to be aware of such situations and be prepared if such an event happens. What should we doing? I think
okay.
that's
I think we have covered almost, and it's Dr.
Yes,
Ravi,
sir.
anything more to ask? Dr. Mithun and Saurav is ready to answer questions even now.
No, really, they have done very well, sir, actually. So I
Yeah.
think they're
Yeah.
prepared. So, and a lot
A
of
few of the
really
questions we asked just to make a point that these things should be in mind for everybody.
Correct.
And
yeah. So that was a fantastic discussion which we had. I think I thank Jacob sir, for bringing his experience and the evidence into this, and Chaitanya adding to the latest changes whatever is happening in the acute stroke management. And I congratulate Mithun and Saurav. You have done really well because as we see a lot of students who are doing for the exams, I think you are well prepared, and that's a really commendable job. Thank you, and we would like to come back again after next week with another interesting topic. Thank you very much.
Thank you, Ravi.
can I take a small moment?
Yeah.
For all those interested in neurocritical care, we have our annual neurocritical care conference happening this month in August 1st to 3rd. For all are interested, please do attend. We have all topics on stroke, subarachnoid hemorrhage, ICH, infections, neuromuscular diseases. We have very senior faculty attending. And I like to thank Yashoda team to giving us this opportunity. And for me, especially because mentoring from where I passed out. Yeah. Thank you.
Thank you. I mean, I think really right in mentioning we have a lot of workshops which are happening hands-on. I think a lot of centers are doing a hands-on workshops. So really, people who are interested in neurocritical care, you have a TCD separate workshop with an extensive, and we at Yashoda High Tech are doing a neurodiagnostic workshop incorporating pupillometry, which we are experiencing it for the first time. So it's a new learning for us also, actually.
Yeah, thank you so much, Dr. Ravi. Thank you, Dr. Chaitanya, my examiner. I think he's into neurology, neurocritical care, so we can see that. And Dr. Venkat and all the Yashoda team for having me here. Hope we have done justice to the trust you have put.
Trust
And
you.
Dr. Mithun and Saurav, congrats. I agree with Dr. Ravi's statement that you're preparing well and you have been guiding well. God bless. Keep going. Okay.
Thank you, sir.
Thank you.
Thank you.